TAHASH, uveitis in rheumatology, types, causes, and treatments. Uveitis is an inflammation of the uvea, the middle layer of the eye that consists of the iris, ciliary body, and choroid. It is a condition that can be associated with various systemic rheumatic diseases, making it a crucial consideration for rheumatologists. Here's a detailed discussion on the types, causes, and treatments of uveitis in the context of rheumatology. Types of uveitis. Uveitis is classified based on the part of the uvea involved and the pattern of inflammation. 1. Anterior uveitis, iritis. Inflammation of the anterior part of the uvea, particularly the iris and ciliary body. Most common form, accounting for about 70 to 90% of all uveitis cases. Common in autoimmune diseases like ankylosing spondylitis and reactive arthritis. 2. Intermediate uveitis involves the vitreous and peripheral retina, often associated with systemic diseases like sarcoidosis, multiple sclerosis, and Behçet's disease. 3. Posterior uveitis involves the choroid, retina, and sometimes the optic nerve, associated with systemic vasculitis, e.g., Behçet's disease and infections. 4. Panuveitis, inflammation affecting all parts of the uvea, anterior, intermediate, and posterior, seen in diseases like Behçet's disease and sarcoidosis. Causes of uveitis in rheumatology. Uveitis can be caused by autoimmune, infectious, and idiopathic factors. In rheumatology, autoimmune causes are particularly important. 1. Autoimmune diseases. Ankylosing spondylitis, the most common rheumatic disease associated with anterior uveitis. It often presents with recurrent unilateral and acute iritis. Reactive arthritis can present with anterior uveitis, especially in HLA-B27 positive individuals. Juvenile idiopathic arthritis, JIA, chronic anterior uveitis is a significant complication in patients with oligoarticular JIA. Behçet's disease, known for causing recurrent panuveitis and retinal vasculitis, which can lead to severe visual impairment. Sarcoidosis can cause granulomatous uveitis, particularly posterior or panuveitis. Systemic lupus erythematosus, SLE, and vasculitides. These can also involve the eye, particularly in the form of posterior uveitis. 2. Infections. Though less common in the context of rheumatology, infections like tuberculosis, syphilis, and herpes zoster can cause uveitis and need to be ruled out in the diagnostic process. 3. Idiopathic. In some cases, no underlying systemic disease is identified, and the uveitis is considered idiopathic. Treatments. Management of uveitis requires a multidisciplinary approach, often involving both rheumatologists and ophthalmologists. Treatment goals include controlling inflammation, preventing vision loss, and managing any underlying systemic disease. 1. Topical corticosteroids. First-line treatment, particularly for anterior uveitis, dexamethasone or prednisolone eye drops are commonly used. 2. Systemic corticosteroids, used in more severe cases or in intermediate, posterior, or panuveitis. Oral prednisone is often prescribed with the dose tapered as inflammation subsides. 3. Immunosuppressive agents, methotrexate, azathioprine, and mycophenolate mofetil, often used in chronic uveitis or when corticosteroids are insufficient. Cyclophosphamide, considered in severe cases of Behçet's disease or vasculitis-related uveitis. For biologic agents, TNF inhibitors, e.g. infliximab, adalimumab, highly effective in managing uveitis associated with spondyloarthropathies and Behçet's disease. Interleukin-6 inhibitors, e.g. tocilizumab, show promise in refractory cases of uveitis, particularly in JIA. Interleukin-1 inhibitors, e.g. anakinra, used in Behçet's disease and other autoinflammatory conditions. 5. Surgery. Vitrectomy may be considered in severe cases with complications such as retinal detachment or vitreous hemorrhage. 6. Treatment of underlying disease. Addressing the systemic condition, such as initiating or optimizing therapy for ankylosing spondylitis, Behçet's disease, or sarcoidosis, is essential in preventing recurrences and managing chronic inflammation. Uveitis is a significant extra-articular manifestation of various rheumatic diseases. Early recognition and appropriate management are crucial to prevent vision loss. Rheumatologists play a vital role in coordinating care with ophthalmologists to control inflammation and treat the underlying systemic disease. Uveitis in juvenile idiopathic arthritis, JIA. Uveitis is a common and serious complication in patients with juvenile idiopathic arthritis, particularly in those with the oligoarticular subtype. It can lead to significant morbidity, including vision loss if not properly managed. Here's an overview of uveitis and JIA, focusing on its presentation, risk factors, and treatment. Epidemiology and risk factors. Prevalence. Uveitis occurs in about 10 to 20% of children with JIA. It is most commonly seen in the oligoarticular subtype, especially in girls with early onset disease. Risk factors, young age at onset. Children who develop arthritis before the age of 7 are at a higher risk. Oligoarticular JIA. This subtype is associated with the highest risk of uveitis, particularly the persistent form of oligoarticular JIA. ANA positivity. Anti-nuclear antibody. ANA positivity is strongly associated with an increased risk of uveitis in JIA. HLA-DRB1 and HLA-DQ alleles. Certain genetic markers are linked to a higher risk of developing uveitis in JIA. By clinical presentation, silent onset. Uveitis in JIA often has a silent or asymptomatic onset, which makes regular screening crucial. Children may not report symptoms until significant damage has occurred. Anterior uveitis. Most commonly, the uveitis seen in JIA is a chronic anterior uveitis. It is typically bilateral but can be asymmetric. Complications. If not detected early, complications such as cataracts, band keratopathy, synechiae, glaucoma, and macular edema can occur, leading to irreversible vision loss. Screening recommendations. Regular ophthalmologic screening is critical for early detection and management of uveitis in JIA. Guidelines typically recommend frequent screening for high-risk patients, e.g. ANA positive, young age at onset. Ophthalmologic exams are recommended every 3 to 4 months. Ongoing monitoring. Even if no uveitis is detected initially, ongoing monitoring is important since uveitis can develop years after the onset of arthritis. Treatment. Treatment of uveitis in JIA aims to control inflammation, prevent complications, and preserve vision. The approach is often multidisciplinary, involving both rheumatologists and ophthalmologists. 1. Topical corticosteroids, the first-line treatment for anterior uveitis. Prednisolone acetate or dexamethasone eye drops are commonly used. Frequent use of steroids can lead to complications like cataracts and glaucoma, so careful monitoring is required. 2. Systemic corticosteroids. For more severe or refractory cases, systemic corticosteroids may be necessary. However, long-term use is generally avoided due to side effects. 3. Immunosuppressive agents. Methotrexate, the most widely used disease-modifying antirheumatic drug DMARD in JIA-associated uveitis. It is effective in controlling both arthritis and uveitis. Mycophenolate mofetil and azathioprine, alternatives to methotrexate in cases where it is ineffective or not tolerated. 4. Biologic agents. TNF inhibitors. Adalimumab and infliximab are the most effective biologics for uveitis associated with JIA, particularly in patients who do not respond to methotrexate alone. Abatacept, a T-cell co-stimulation modulator that may be used in some cases of JIA-associated uveitis. Tocilizumab, an IL-6 inhibitor that has shown promise in refractory cases. 5. Surgery. Surgical interventions may be necessary for complications such as cataracts or glaucoma. However, these procedures carry risks and should be considered carefully. 6. Multidisciplinary care. Close collaboration between the rheumatologist and ophthalmologist is essential to manage both the systemic disease and the ocular inflammation effectively. Regular follow-up and adjustment of therapy based on disease activity and response to treatment are crucial. Prognosis. With early detection and aggressive treatment, the prognosis for preserving vision in children with JIA-associated uveitis has improved significantly. However, delayed diagnosis or inadequate control of inflammation can lead to irreversible complications and vision loss. Conclusion. Uveitis is a significant concern in children with JIA, particularly in those with oligoarticular disease and ANA positivity. Early screening, appropriate use of immunosuppressive therapies, and regular monitoring are key to preventing vision-threatening complications. Uveitis in Behçet's disease. Behçet's disease is a chronic multisystem inflammatory disorder characterized by recurrent oral and genital ulcers, skin lesions, and uveitis. Uveitis is one of the most severe manifestations of Behçet's disease and can lead to significant visual impairment if not treated promptly. Here's a detailed discussion of uveitis in the context of Behçet's disease, including its presentation, causes, and treatment options. Epidemiology, prevalence. Uveitis occurs in 50 to 70% of patients with Behçet's disease and is more common in males. It is a leading cause of blindness in these patients, particularly in areas where Behçet's disease is endemic, such as the Middle East and East Asia. Risk factors. Young males, particularly those in their 20s and 30s, are at higher risk for severe ocular involvement. The presence of HLA-B51 has been associated with more severe disease, including ocular complications. Types of uveitis in Behçet's disease. Uveitis in Behçet's disease can present in various forms, often with a relapsing and remitting course. 1. Anterior uveitis. Less common in Behçet's disease, but can still occur. Presents with pain, redness, and photophobia. 2. Posterior uveitis, more common and typically more severe in Behçet's disease, involves the retina and choroid and can lead to complications such as retinal vasculitis, retinal hemorrhages, and macular edema. 3. Panuveitis, a hallmark of ocular involvement in Behçet's disease, affecting all layers of the uvea, anterior, intermediate, and posterior. Can lead to hypopyon, a layering of inflammatory cells in the anterior chamber, which is characteristic of Behçet's related uveitis. 4. Retinal vasculitis. Behçet's disease often causes occlusive retinal vasculitis, which can lead to significant retinal ischemia and vision loss. Pathogenesis, autoimmune inflammation. Uveitis in Behçet's disease is driven by an autoimmune process, with immune-mediated damage to the ocular tissues. Vasculitis. Behçet's disease is a vasculitic disorder, and the inflammation of blood vessels in the eye, retinal vasculitis, is a key feature of uveitis in this condition. T-cell activation. T-cell-mediated immune responses are implicated, with elevated levels of pro-inflammatory cytokines, e.g. TNF-α, IL-6, contributing to the ocular inflammation. Clinical presentation. Recurrent episodes. Uveitis in Behçet's disease tends to be relapsing and remitting, with episodes of acute inflammation followed by periods of remission. Bilateral involvement. The disease usually affects both eyes, although the severity may differ between them. Hypopyon. A notable feature in some cases presenting as a white or yellowish layer of pus-like material in the anterior chamber of the eye, though it is not always present. Complications. Vision loss. Recurrent episodes of inflammation can lead to complications such as cataracts, glaucoma, retinal detachment, and optic atrophy, all of which can result in permanent vision loss. Macular edema. Swelling of the macula is a common complication and a significant cause of vision loss in these patients. Treatment. The treatment of uveitis in Behçet's disease is aimed at controlling inflammation, preventing relapses, and preserving vision. Due to the relapsing nature of the disease, long-term treatment is often necessary. 1. Corticosteroids, topical corticosteroids, used for anterior uveitis to reduce inflammation in the anterior chamber. Systemic corticosteroids, oral or intravenous corticosteroids, e.g. prednisone or methylprednisolone, are used for severe posterior uveitis or panuveitis. However, corticosteroids are typically used in combination with other immunosuppressive agents to minimize long-term use and its side effects. 2. Immunosuppressive agents. Azathioprine, a common first-line immunosuppressive agent in Behçet's-related uveitis, effective in reducing relapses and preserving vision. Cyclosporin, particularly effective for severe posterior uveitis and retinal vasculitis. However, it must be used with caution due to its nephrotoxic effects. Cyclophosphamide, used in severe cases, particularly in patients with aggressive ocular disease. Methotrexate, an alternative for patients who do not tolerate azathioprine or in combination with other agents for refractory cases. 3. Biologic therapies, TNF inhibitors, e.g. infliximab, adalimumab. These are highly effective in managing severe refractory uveitis in Behçet's disease, especially in patients who do not respond to conventional immunosuppressive therapy. Infliximab, in particular, has been shown to reduce the frequency of relapses and improve visual outcomes. Tocilizumab. These have been used in refractory cases, especially in patients who do not respond to TNF inhibitors. Number 4, interferon alpha, used in some cases of refractory uveitis and Behçet's disease, especially in regions where other biologic therapies may not be available. 5, surgical interventions. Surgery may be needed for complications such as cataracts, glaucoma, or retinal detachment. However, surgery carries a higher risk in these patients due to the underlying inflammatory process. Number 6, long-term monitoring. Regular ophthalmologic examinations are essential to monitor for disease activity and complications. Patients need close follow-up even during periods of remission, as relapses can occur unexpectedly. Prognosis. Variable outcomes. The prognosis for uveitis and Behçet's disease can be variable, with some patients achieving good control of inflammation and preservation of vision, while others may suffer significant visual loss despite treatment. Importance of early and aggressive treatment. Early diagnosis and aggressive treatment are crucial to prevent irreversible complications and preserve vision. Conclusion. Uveitis in Behçet's disease is a serious and potentially vision-threatening condition that requires a multidisciplinary approach to management. Early recognition, aggressive treatment with immunosuppressive agents and biologics, and regular monitoring are essential to prevent long-term complications and optimize visual outcomes for patients. Uveitis in spondyloarthritis, types, causes, and treatment. Uveitis is a common extra-articular manifestation of spondyloarthritis, SPA, particularly in individuals with ankylosing spondylitis, AS, and other related conditions. Spondyloarthritis encompasses a group of inflammatory rheumatic diseases, including ankylosing spondylitis, reactive arthritis, psoriatic arthritis, and inflammatory bowel disease, IBD-associated arthritis. Uveitis can significantly impact the quality of life for patients with SPA and requires careful management. Here's an overview of uveitis in the context of spondyloarthritis, focusing on its presentation, causes, and treatment options. Epidemiology. Prevalence. Uveitis occurs in 30 to 40% of patients with ankylosing spondylitis, making it the most common extra-articular manifestation. It is less common in other forms of spondyloarthritis, but still occurs more frequently than in the general population. Gender and HLA-B27 association. Uveitis in SBA is more common in HLA-B27 positive individuals, particularly males, who also tend to have a more severe and recurrent disease course. Up to 50% of HLA-B27 positive patients with AS may experience uveitis during their lifetime. Types of uveitis in spondyloarthritis. Uveitis in spondyloarthritis is typically anterior but can vary in severity and recurrence. 1. Anterior uveitis, iritis, the most common form associated with spondyloarthritis, characterized by acute onset of unilateral eye pain, redness, photophobia, and blurred vision. Tends to be recurrent, affecting one eye at a time, but may alternate between eyes during relapses. 2. Posterior uveitis, less common in SBA, but may occur, leading to inflammation in the retina and choroid. Can cause more severe visual disturbances, including floaters and loss of vision, and may be associated with more systemic inflammation. 3. Panuveitis, rare in spondyloarthritis, but represents inflammation of all layers of the uvea, anterior, intermediate, and posterior. This can lead to a higher risk of complications such as macular edema or retinal detachment. Pathogenesis, immune-mediated inflammation. Uveitis and spondyloarthritis is believed to be driven by immune dysregulation. HLA-B27 plays a critical role, but the exact mechanisms are not fully understood. Inflammatory activation of inflammatory pathways involving cytokines such as tumor necrosis factor alpha, TNFI, and interleukin-17, IL-17, leading to ocular inflammation. Clinical presentation. Acute onset. Patients typically present with sudden onset of unilateral symptoms, including eye pain, redness, sensitivity to light, photophobia, blurred vision, tearing, recurrent nature. Uveitis in SBA is often recurrent, with episodes lasting weeks to months. These flares can alternate between the eyes. Complications, cataracts and glaucoma. Recurrent episodes of inflammation and the use of corticosteroids can lead to cataracts or glaucoma. Posterior synechia. Adhesions between the iris and the lens can form, potentially leading to complications such as distorted pupil shape or angle closure glaucoma. Macular edema. Chronic inflammation can cause swelling of the macula, leading to blurred central vision and potentially permanent visual impairment. Diagnosis, ophthalmologic examination. An ophthalmologist will assess for signs of inflammation in the anterior chamber, posterior segment, and vitreous. Systemic evaluation. Given the association with spondyloarthritis, patients presenting with uveitis should be evaluated for symptoms of axial or peripheral arthritis, enthesitis, and other ETSPE-related conditions. Treatment. The management of uveitis and spondyloarthritis requires both local treatment to control ocular inflammation and systemic therapy to manage the underlying rheumatic disease. 1. Topical corticosteroids. First-line treatment. Prednisolone acetate or dexamethasone eye drops are the mainstay for acute anterior uveitis. Tapering doses. The frequency is gradually reduced as the inflammation resolves to minimize the risk of side effects, such as increased intraocular pressure. 2. Systemic corticosteroids, used for more severe or refractory cases, especially when posterior uveitis or panuveitis is involved. Oral corticosteroids like prednisone can be used short-term but are not recommended for long-term management due to side effects. 3. Cycloplegics. Eye drops such as atropine or cyclopentolate are used to dilate the pupil and prevent the formation of synechiae, adhesions between the iris and the lens. 4. Systemic immunosuppressive therapy. Methotrexate can be used in cases where uveitis is recurrent or chronic, particularly in combination with corticosteroids to reduce the need for long-term steroid use. Azathioprine and cyclosporine, alternatives to methotrexate, especially in patients with refractory uveitis. 5. Biologic agents, TNF inhibitors, e.g. infliximab, adalimumab. These are highly effective in controlling both spondyloarthritis and associated uveitis. They reduce the frequency and severity of uveitis flares and are preferred in patients with frequent recurrences. Secukinumab, IL-17 inhibitor, has shown efficacy in treating axial spondyloarthritis and uveitis in certain patients. Golimumab, another TNF inhibitor that is effective for treating both SPA and associated uveitis. 6. Long-term monitoring. Regular eye exams. Patients with SPA should undergo regular ophthalmologic evaluations, even during asymptomatic periods, to monitor for signs of inflammation and prevent complications. Multidisciplinary approach. Collaboration between rheumatologists and ophthalmologists is crucial to ensure optimal management of both the systemic disease and the ocular manifestations. Prognosis. Good response to treatment. Most patients with SBA-associated uveitis respond well to treatment, particularly with the use of biologic agents. Risk of recurrence. Despite treatment, the risk of recurrence remains high, particularly in HLA-B27 positive patients. Lifelong monitoring is often required to manage flares and prevent complications. Vision preservation. With early detection and appropriate management, most patients can preserve their vision and avoid severe complications. Conclusion. Uveitis is a common and serious extraarticular manifestation of spondyloarthritis, particularly in HLA-B27 positive individuals. Early diagnosis, appropriate local and systemic treatment, and regular follow-up are essential to control inflammation, prevent recurrences, and preserve vision in affected patients. A multidisciplinary approach involving both rheumatologists and ophthalmologists is key to optimal patient outcomes. Secukinumab in spondyloarthritis with uveitis, benefits and hazards. Secukinumab is a human monoclonal antibody that targets interleukin-7A, IL-7A, a key cytokine involved in the inflammatory pathways of spondyloarthritis, SPA. It has been approved for the treatment of ankylosing spondylitis, AS, non-radiographic axial spondyloarthritis, and psoriatic arthritis. Given the role of IL-17 in both joint and ocular inflammation, secukinumab has been considered for the treatment of uveitis in patients with SPA. Below is a discussion of the potential benefits and hazards of using secukinumab in spondyloarthritis patients with uveitis. Benefits of secukinumab in spondyloarthritis with uveitis. 1. Efficacy in controlling axial and peripheral disease. Proven efficacy in SPA. Secukinumab has demonstrated efficacy in reducing symptoms and inflammation in axial and peripheral forms of spondyloarthritis including ankylosing spondylitis and psoriatic arthritis. This can lead to improved quality of life for patients by controlling joint pain, stiffness, and other systemic manifestations of the disease. Sustained response. Studies have shown that secukinumab can provide sustained improvement in SBA symptoms, including spinal mobility and reduction in radiographic progression. 2. Potential for reducing uveitis flares, targeting IL-17A. Since IL-17A plays a role in the inflammatory cascade of both spondyloarthritis and uveitis, secukinumab may theoretically reduce the frequency and severity of uveitis flares. Some case reports and smaller studies have suggested that secukinumab may be beneficial for patients with recurrent uveitis associated with SBA, although this is not yet definitively proven. Steroid-sparing effect. Secukinumab may reduce the need for corticosteroids, which are commonly used to manage acute uveitis flares, but are associated with significant side effects when used long-term. 3. Less frequent administration, convenient dosing. Secukinumab is administered subcutaneously, with an induction phase followed by maintenance dosing, typically every 4 weeks. This may offer more convenience compared to frequent corticosteroid eye drops or systemic immunosuppressive therapies. Hazards and limitations of secukinumab in spondyloarthritis with uveitis. 1. Limited data on efficacy in uveitis, mixed results in clinical trials. While secukinumab is effective in treating spondyloarthritis, clinical trials specifically evaluating its efficacy in uveitis have shown mixed results. Some studies, e.g., the Sunrise and Ensure trials, did not demonstrate a significant reduction in uveitis recurrence compared to placebo, raising concerns about its effectiveness for this particular indication. Off-label use, as of now, is not officially approved for the treatment of uveitis, and its use in this setting would be considered off-label. 2. Risk of uveitis flares, paradoxical uveitis. There have been reports of paradoxical worsening or onset of uveitis in some patients treated with secukinumab. This phenomenon, although rare, has been observed with other biologics, e.g. TNF inhibitors, as well, and is not fully understood. Patients need to be monitored closely for any signs of new or worsening ocular inflammation. 3. Adverse effects. Infection risk. Like other biologics, secukinumab suppresses parts of the immune system, which can increase the risk of infections, including upper respiratory tract infections, fungal infections, and in rare cases, serious infections such as tuberculosis. Gastrointestinal effects. Some patients may experience diarrhea or abdominal pain as side effects of secukinumab. Injection site reactions. Pain, swelling, or redness at the injection site is relatively common but usually mild. Possible exacerbation of Crohn's disease. Secukinumab may worsen inflammatory bowel disease, IBD, in patients with underlying Crohn's disease, which is relevant for patients with SBA since there is a known association between SBA and IBD. 4. Cost and accessibility. High cost. Secukinumab is a high-cost biologic therapy which may limit access for some patients. Insurance coverage and prior authorization requirements can be barriers to treatment. Long-term commitment. Patients on secukinumab often need long-term treatment, which adds to the overall healthcare costs. Stopping therapy can result in a return of both joint and ocular symptoms. Conclusion. Secukinumab benefits. Secukinumab is effective in managing the joint and spinal symptoms of spondyloarthritis and may have a role in reducing the frequency of uveitis flares in some patients, potentially decreasing reliance on corticosteroids. Caution required. However, its role in treating uveitis specifically remains uncertain due to mixed clinical trial results and the potential for paradoxical uveitis. Close monitoring is essential, particularly in patients with a history of recurrent uveitis. Individualized decision. The decision to use secukinumab in SBA patients with uveitis should be individualized, taking into account the patient's disease severity, previous treatment responses, and potential risks. Collaboration between rheumatologists and ophthalmologists is crucial to ensure optimal management of both systemic and ocular manifestations. TASH uveitis in systemic lupus erythematosus, SLE. Systemic lupus SLE is a chronic autoimmune disease that can affect multiple organs, including the skin, kidneys, joints, and nervous system. While ocular involvement is common in SLE, uveitis is relatively rare compared to other manifestations like keratoconjunctivitis sicca, dry eye, and retinal vasculitis. Nevertheless, when uveitis occurs in SLE, it can be vision threatening and requires prompt recognition and treatment. Here's an overview of uveitis in the context of SLE, including its types, causes, and treatment. Epidemiology, prevalence. Uveitis is a rare manifestation of SLE, occurring in less than 1 to 2% of patients. When present, it can involve different parts of the uveal tract and may be associated with more severe systemic disease. Gender and age. As with SLE in general, uveitis associated with lupus is more common in females, particularly those of childbearing age. Types of uveitis in SLE. Uveitis in SLE can involve different parts of the uvea, anterior, intermediate, or posterior, though posterior segment involvement tends to be more common. 1. Anterior uveitis involves inflammation of the iris and ciliary body. Symptoms include eye pain, redness, photophobia, and decreased vision. It is less commonly seen in SLE compared to other autoimmune diseases like spondyloarthritis. 2. Posterior uveitis involves inflammation of the choroid and retina, may present with floaters, visual field defects, and decreased vision, often associated with more severe systemic lupus activity and can be accompanied by retinal vasculitis or optic nerve involvement. 3. Panuveitis involves inflammation of the entire uveal tract, anterior, intermediate, and posterior segments. This is rare in SLE but represents a severe form of uveitis that can lead to significant visual impairment if not treated promptly. Pathogenesis. Autoimmune mechanisms. Uveitis in SLE is driven by autoimmune inflammation, where the body's immune system mistakenly attacks its own tissues, including the uveal tract. Antibody and immune complex deposition in ocular tissues can lead to inflammation. Vasculitis. SLE is known for causing vasculitis, and when this involves the blood vessels of the eye, it can lead to retinal vasculitis, which may be a component of posterior uveitis. This can result in ischemia, hemorrhages, and potentially irreversible vision loss. Clinical presentation. Symptoms. Patients with uveitis in SLE may present with eye pain, redness, photophobia, and blurred vision. Posterior uveitis can lead to floaters, visual field loss, or a sudden decrease in vision. Systemic association. Uveitis in SLE often occurs during periods of systemic disease flare, particularly when other organ systems, e.g., kidneys, central nervous system, are involved. Hanesh complications. Cataracts and glaucoma. As with other forms of uveitis, prolonged inflammation and the use of corticosteroids can increase the risk of cataract formation and glaucoma. Retinal detachment. Severe inflammation can lead to complications like retinal detachment, particularly in cases of posterior uveitis or retinal vasculitis. Vision loss. Without prompt treatment, chronic inflammation can cause permanent damage to ocular structures, leading to irreversible vision loss. Diagnosis. Ophthalmologic evaluation. An eye examination by an ophthalmologist is critical for diagnosing uveitis. Slit lamp examination can reveal anterior uveitis, while dilated fundus examination can detect posterior segment involvement. Imaging. Fluorescein angiography and optical coherence tomography, OCT, may be used to assess retinal involvement and monitor response to treatment. Systemic workup. Given the association between uveitis and systemic lupus flares, a comprehensive workup including serological tests, e.g., anti-dsDNA antibodies, complement levels, and evaluation of other organ systems is necessary. TASH treatment. The treatment of uveitis in SLE aims to control inflammation, manage systemic disease activity, and prevent complications. 1. Topical corticosteroids. Anterior uveitis. Topical corticosteroid eye drops, e.g., prednisolone acetate, are the mainstay for treating anterior uveitis. Cycloplegics. These agents are often used in conjunction with corticosteroids to dilate the pupil and reduce pain caused by iris spasm. 2. Systemic corticosteroids. Posterior or panuveitis. Systemic corticosteroids, e.g., oral prednisone, are often required for more severe cases, particularly when posterior segment involvement is present. High-dose intravenous corticosteroids may be used in acute, sight-threatening situations. 3. Immunosuppressive agents. Steroid-sparing agents. For patients with recurrent or chronic uveitis or those who require prolonged corticosteroid therapy, Immunosuppressive agents, such as methotrexate azathioprine or mycophenolate mofetil, may be used to control both ocular and systemic lupus activity. Cyclophosphamide. In cases of severe refractory uveitis or systemic lupus flares involving vital organs, e.g., lupus nephritis, cyclophosphamide may be considered. 4. Biologic agents. Rituximab. This anti-CD20 monoclonal antibody, which depletes B cells, has been used in refractory cases of lupus-associated uveitis, especially when standard immunosuppressive agents have failed. Belimumab. An anti-BAFF antibody used in SLLE may be considered in selected cases, though its efficacy in uveitis specifically is not well established. 5. Antimalarials, e.g., hydroxychloroquine. Systemic control. Hydroxychloroquine is often used as part of the baseline therapy in SLE and may help control systemic inflammation. Although not directly used for treating uveitis, it can reduce the frequency of flares and the need for systemic corticosteroids. 6. Surgical interventions. Surgery may be necessary for complications such as cataracts or glaucoma. However, surgery in uveitis patients carries a higher risk of complications due to the underlying inflammatory process. Prognosis. Variable outcomes. The prognosis for uveitis in SLE can be variable depending on the severity of the ocular involvement and the systemic disease. With early diagnosis and aggressive treatment, many patients can achieve good control of inflammation and preserve vision. Risk of relapse. Uveitis in SLE may recur, especially during periods of systemic lupus activity, necessitating long-term follow-up and treatment adjustment as needed. Conclusion. Uveitis and systemic lupus erythematosus is a rare but potentially serious complication that requires prompt recognition and aggressive management. Early intervention with corticosteroids, immunosuppressive agents, and possibly biologic therapies can help control inflammation and prevent complications. Multidisciplinary collaboration between rheumatologists and ophthalmologists is essential for optimal management of both systemic and ocular manifestations of the disease. Use of hydroxychloroquine in SLE patients with uveitis, benefits and hazards. Hydroxychloroquine HCQ is a commonly used antimalarial drug in the management of systemic lupus erythematosus SLE. It plays a crucial role in controlling SLE-related symptoms and preventing disease flares. Its use in patients with SLE who have uveitis is of particular interest due to its effects on the underlying systemic disease and its potential impact on ocular manifestations. Benefits of hydroxychloroquine in SLE patients with uveitis. 1. Disease control, systemic lupus management. HCQ is effective in controlling systemic lupus erythematosus, including skin rashes, joint symptoms, and serositis. By reducing the overall disease activity, HCQ may help decrease the frequency and severity of uveitis flares. Prevention of flares. Regular use of HCQ has been shown to reduce the frequency of lupus flares. Since uveitis often correlates with disease flares, effectiveness of SLE can indirectly benefit patients with ocular manifestations. 2. Reduction in steroid use, steroid-sparing effect. By controlling disease activity, HCQ can reduce the need for systemic corticosteroids, which are often used to treat acute uveitis. This is advantageous because long-term corticosteroid use can lead to significant side effects, including ocular complications like cataracts and glaucoma. Number 3, additional ocular benefits, anti-inflammatory properties. Hydroxychloroquine has mild anti-inflammatory effects that can contribute to overall ocular health. While not specifically indicated for uveitis, it may have some beneficial effects on the inflammation of the eye. 4. Safety profile. Long-term use. HCQ has a well-established safety profile when used long-term in SLE patients. Its use in managing lupus-related conditions is supported by extensive clinical experience and research. Hazards and limitations of hydroxychloroquine in SLE patients with uveitis. 1. Limited efficacy for acute uveitis, not a primary treatment for uveitis. HCQ is not a primary treatment for acute uveitis or severe ocular inflammation. It is primarily used for systemic lupus management and may not provide rapid control of acute uveitis. More aggressive treatments, such as corticosteroids or immunosuppressives, are typically required for managing uveitis. 2. Retinal toxicity risk. Chloroquine retinopathy. Long-term use of HCQ is associated with a risk of retinal toxicity, which can manifest as maculopathy or retinopathy. Although this risk is relatively low, it becomes a concern in patients with existing ocular inflammation. Monitoring required. Regular ophthalmologic screening is recommended to monitor for signs of retinal toxicity, especially in patients on long-term HCQ therapy. Early detection can help prevent irreversible damage. 3. Potential drug interactions. Interaction with other medications. HCQ may interact with other medications used to manage SLE and uveitis, potentially affecting the efficacy of treatment. Coordination with a healthcare provider is essential to manage these interactions. 4. Not a substitute for targeted uveitis therapy. Need for comprehensive management. While HCQ helps in controlling the systemic lupus disease, it should not replace targeted therapies specifically designed for uveitis. The management of uveitis often requires additional treatments like corticosteroids, immunosuppressive agents, or biologics. Conclusion. Hydroxychloroquine is a valuable medication in the management of systemic lupus erythematosus, with benefits including disease control, reduction in steroid use, and an overall favorable safety profile. However, its role in directly managing uveitis is limited. While HCQ can contribute to reduce disease flares and may have some mild anti-inflammatory effects, it is not a primary treatment for acute uveitis. Careful monitoring for retinal toxicity is necessary with long-term use. Comprehensive management of uveitis in SLE often requires a combination of therapies, including corticosteroids, immunosuppressives, and possibly biologic agents, in addition to HCQ. Regular collaboration between rheumatologists and ophthalmologists is crucial for optimizing patient care.